Yes, good afternoon, friends. Today on the World TB Day, I welcome all the family physicians across the India. It is very sad to announce that past president of FFPI, Dr. R.G. Jimolia, uh, he left us uh, to the heaven yesterday. He is a renowned physician, and his tireless efforts to upbring the FFPI is remarkable. So here we all give him a Shraddhanjali. His all the remarkable job did for the FFPI is really unremarkable and unreplaceable. Now I request Dr. Raman Kumar to start the session. Dr. Raman Kumar, please.
Thank you, Dr. Pragnesh, for initiating this very important collaboration between FFPAI and AFPI. We have been talking and discussing about this collaboration for the long time. And this one is the first joint CME organized by FFPAI and AFPI for their respective members. And the organizations will be introduced later on by the respective speakers from both organizations. But to have this CME on tuberculosis is not only contextual, but very, very important from India's aspiration of overcoming the menace of tuberculosis in India. Because if you look at the global burden of tuberculosis, India is one of the countries where we have all types of tuberculosis prevalent. Not just pulmonary tuberculosis, but across all disciplines, all specialties, we see tuberculosis. And in general practice, family practice, we see all types of patients, all age groups, all genders, and we often encounter tuberculosis in our day-to-day practice. So knowing about current practices, current guidelines, current status of tuberculosis is very important, pertinent to all of our members who are across India. It is important that we learn not only the general aspects of tuberculosis, but small nuances of practice also. And I hope, and we have a very learned speaker for today, Dr. HARDIK, who is the program director for tuberculosis, and I'm sure his expertise will benefit all of us. Sorry, I could not read the PowerPoint because I could not open his introduction in my mobile. May I request Dr. Pragnesh Shah to briefly introduce him to our audience, to our participating members. This talk is being disseminated through YouTube channel, and I hope we will have many audiences for today, now live, and later on also on the recorded session. May I request Dr. Pragnesh to introduce Dr. HARDIK, please.
Thank you, Dr. Raman Kumar. Dr. Raman Kumar is a president of the AFPI, and he is already doing the great job for the family physician across the country, and he is trying to start DNB and MD family medicine courses across the country, and for this he is meeting government officials very frequently. So we are really thankful to you, Dr. Raman Kumar. Now, before introducing Dr. HARDIK, I request Dr. Dhiren Bhai, the treasurer of the FFPI, to brief about FFPI.
Thank you, Dr. Pragnesh Bhai. FFPI is the Federation of Family Physicians Associations of India. It is functioning since 1986. We have already almost 30 units as a member of our federation and running about more than 10 states throughout the India. And we are trying to include more and more units, so more and more family physicians can be involved and can be active in their academically and the other way also. Rightly saying, Dr. Raman Kumar, actually tuberculosis, when we are shouting about the corona since last 2 to 3 years, actually the death rate by tuberculosis was equally or more than that comparatively. But we are habituated to that thing also. So we are not talking about anything at all. So today, World Tuberculosis Day, it is our duty to say, to inform the society about tuberculosis and to guide the exact treatment line and what are the notification schedules and protocols so they can be treated very well. So thank you, Dr. Pragnesh Bhai, for giving me the chance, and hand over to Dr. Pragnesh Bhai.
Thank you, Dr. Dhiren Mehta. Dr. HARDIK NAKSHIWALA is basically a man from the preventive medicines field. He worked as an epidemiologist under the National Control of Disease Program at district and state level for since last 4 to 5 years. Currently working as a WHO consultant under the National Tuberculosis Eradication Program since 2020, looking after Gujarat and Dadra Nagar zone. He is very much interested and working hard to eradicate tuberculosis from the India. So over to you, Dr. HARDIK. Dr. HARDIK, please.
Okay, sir. Thank you, sir. Thank you for the introduction. Good afternoon, all. I'm Dr. HARDIK NAKSHIWALA. I suppose my voice is not interrupting.
Yeah, but your video is not off, okay. I think.
So,
it is off.
Yeah.
Yes.
So now I will be visible.
Yes.
Okay. Yes.
So, yes. Thank you, sir. So I'm sharing my screen, but in between, if my voice gets interrupted or my screen or slide is not moving, then please let me know, sir.
Yes.
So this is my screen. I suppose it is visible.
Yes, visible.
Okay. So as Dr. Raman sir has said that TB has been with us for 5,000 years, and it is a wayward disease because it has a long generation time. So now, earlier it was a TB control program, and we were managing TB as a disease. But now TB is elimination program. So in my session, I will discuss mainly the evolution from the control program to the elimination program. What are the provisions and services available in NTEP, and what is the role of family physician under NTEP. So if my voice gets interrupted or if my slide is not moving, then please let me know. I will switch down my video. So this is the highest level of commitment shown by our Prime Minister Narendra Modi sir, and it was the commitment and it was a moral commitment by the nation to end TB, right? And ending TB and going towards the elimination stage is the journey now for TB. So what is the end TB? The end TB target are provided by WHO, and it is ending TB by 2035. So you can see it in the the rightmost column, that is reduction in the number of TB deaths. Compared to 2015, there should be reduction of 95% TB deaths in 2035. Reduction in incidence up to 90% in 2035 compared to 2015 level. And there should be no catastrophic cost due to TB to any TB patient's family. So, and TB target are provided by WHO, and that these targets are for 2035, and the baseline year is 2015. Now, SDG has provided another targets. These are the interim targets. That is 90% reduction in mortality, 80% reduction in incidence, and zero out-of-pocket expenditure or catastrophic cost due to TB. And the commitment shown by our Honorable Prime Minister is that our country will achieve this target, that is SDG target, by 2025. Right? So 80% reduction in incidence, 90% reduction in mortality due to TB, and zero out-of-pocket expenditure due to TB to TB patient and TB family, the patient's family, will be the end TB target for 2025, which is the commitment shown by our Honorable Prime Minister. So, as Dr. Raman sir has mentioned, that our country is sharing almost 1/3 of the TB burden of the global level. So if you can see this global tuberculosis report, which shows data of 2021, right? So TB incidence, our country is sharing the rightmost column, that is 28% of the global incidence. TB incidence 36% of TB mortality in cases, 26% of the global cases. Treatment only, and strengthen your TB control program, then you can have 8 to 10% decline every year. So what our Prime Minister's commitment can be fulfilled by preventing TB with our existing TB control program. So prevention is the main strategy under National TB Elimination Program. So from 2019, the nomenclature has been changed from Revised National TB Control Program to National TB Elimination Program. And due to this prevent strategy, we can achieve this elimination phase or ending TB phase by 2025 or afterwards. Then second pillar under the National Strategic Plan is detect early identification of presumptive cases by highly sensitive diagnostic tool. So earlier we were using microscopy and X-ray. Microscopy has sensitivity up to 30%, but specificity of 70%, while X-ray has reverse sensitivity and specificity, means sensitivity around 70% and specificity around 30%. But both of these tests were not highly sensitive. There are highly sensitive tests available in market, and National TB Elimination Program is utilizing these highly sensitive, namely NAT testing, that is nucleic acid amplification testing. There are two types of NAT machines, CBNAT and TrueNAT. And as per the National Strategic Plan, country will ensure block level, means taluka level saturation of diagnostic machinery by NAT tools. Third one is treat, means expanded treatment and management of DRTB in line with WHO guideline. So currently we are providing quality assured TB and drug sensitive TB and drug resistant TB treatment as per WHO guideline. There will be inclusion of the ICT based treatment support, means treatment adherence will be monitored by ICT based tools, and there should be strengthening of drug and logistic management. And in the build program, there will be community engagement, human resource management, ensuring funding and promoting TB research, right? So these are the airborne infection control measures will be implemented in government facilities. First one is AIC kit, providing AIC kit to patient and explaining them how to use it, right? And ensuring they are using it by our program personnel. Then fast tracking TB patient or any chest symptomatic patient coming to facility having adult OPD more than 100. Fast tracking means if a patient comes to a facility having high patient load, then at the case registration facility, the person in the case window will ask him whether he or she is having chest symptoms. If patients say yes, then this fast track symbol will be put on his case paper, and these patients will be prioritized in everywhere in the facility, at doctor's cabin, at pharmacy, at laboratory, for ensuring early disposal of the patient so that patient cannot transmit infection to other patients. These patients will be provided mask at the case window and will be counseled to keep the mask on while he is in the facility premises. And third one is the cuff corner. Cuff corner means a separate area identified for extraction of the sputum where other person's movement will not be happening in the facility. This area will be a open space and direct sunlight will be ensured by the facility, right? So there are other indoor airborne infection control measures also, but we will not go into the details. So second one in the prevent strategy is providing TPT. TB preventive treatment is the main strategy for preventing endogenous reactivation of the TB disease, right? So what we have discussed earlier, that around 30 to 40% of Indians in general population, they are already infected with TB, right? And if you want to prevent exogenous reinfection, TB preventive treatment is the main strategy. So programmatically, program is going to provide TB preventive treatment in phase manner. First, in this year, we have already started providing TB preventive treatment, but first, in the first one phase, it will be to the household context of pulmonary microbiologically confirmed TB patients, household context, right? So TB preventive treatment will be provided to pulmonary microbiologically confirmed household context of a index TB patients. But the main catch is active TB is absolute contraindication for TPT. So while providing TPT, our health staff and every doctor will rule out active TB. And if the patient doesn't have active TB, then as per their consent, they will be provided TPT, right? So TB preventive treatment is the main basic strategy for prevention, for preventing endogenous reactivation. And as a first phase, we have started providing TPT to pulmonary microbiologically confirmed household TB patients. So what we have earlier discussed, that in general population, the TB infection prevalence is around 30 to 40%. But in pulmonary microbiologically confirmed TB patients, this proportion is around 70%. So the study has been done in UP, and from this study, there are higher chances of TB infection in pulmonary microbiological confirmed TB patients household context, right? So TPT will be provided to pulmonary microbiologically confirmed TB patients household context after ruling out active TB. So these are the main groups. So earlier, the program already been providing TPT to HIV patients and household context less than 5 years. Now, under PMTPT, that is Programmatic Management of TB Preventive Treatment, we have expanded this beneficiary group to all household contact of pulmonary microbiologically confirmed TB patients. And in the next phase, we are going to include patients with immunosuppression, right? So there are different criteria of providing TPT, right? But TB preventive treatment has already been started in your district and in your states. So these are diagnostic modalities available under NTEP program. The first one is CBNAT, or this expert MTB RIF, that can detect MTB complex as well as rifampicin resistance responsible gene. Right, this is genotypic test that can provide you the result of resistant gene is present or not. Right. The another one is expert MTB XDR. Means the first one is providing MTB complex present or not plus rifampicin resistance gene present or not. But this will provide you additional results, not only rifampicin, but isoniazid, fluoroquinolone, second line injectables, and ethionamide result. Third one is TrueNAT. It is Make in India product. The CBNAT machine requires AC, UPS, platform, everything, right? But TrueNAT doesn't require everything. It is a point of care test. You can do this TrueNAT test at patient's home also, right? It is a Make in India product. All three tests give positive results within 2 hours, right? The fourth one is line probe assay, which is a PCR. It requires 3 rooms and biosafety cabinets, right? But it provides result within 72 hours. The 5th one is solid culture, that is algae medium. It can provide result within 8 weeks. And liquid culture, last one, it is MGIT, that is Mycobacterium growth inhibitor tubes, which can provide result within 2 weeks. Positive result. But for negative result, we have to wait for 6 weeks, right? So final result will come after 6 weeks. So these battery of tests are available under NTEP. The first 4 are genotypic tests, right? Genotypic tests have higher sensitivity, but they are not used for prognostic purposes, right? Because these tests are dependent on gene, and a dead bacilli can also give positive tests because genes are available, right? So for prognosis, we have to rely on phenotypic tests. So liquid culture and solid culture are phenotypic tests, right? So for follow-up, you can use liquid culture or solid culture, but for detection and for detection, early detection of drug resistance, we are using first 4 tests. So this is first one is the above one is Sebinat machine. The below one is TrueNAT machine. It is fully automated cartridge-based or chip-based nucleic acid amplification test. We can say that these machines are miniature PCR, which provide you result within 2 hours, right? It is high sensitivity, higher specificity, but for mainly sputum samples, right? There are equivocal sensitivity or specificity with other extrapulmonary samples, right? But whenever you send sample in Falcon tube for TrueNAT or Sebinat, please, the sample should not contain blood or formalin should not be added for the preservation, right? But again, I am reiterating that the sensitivity is highest for sputum samples. So these are fixed dose combinations available under NTEP. These are WHO quality assured products available, and these products are same which are available in private sector, right? So these fixed dose combinations are being provided as per weight band, under the observation of the treatment supporter at same time at regular interval. And after your suggestion from private sector, now NTEP is providing daily regimen, daily treatment, right, under treatment support. So what is the coming to the role of family physician? First, you have to suspect TB, right? Mainly, there are symptoms of TB. First is cough more than 2 weeks, fever more than 2 weeks, night sweat, and weight loss, significant weight loss, right? These 4 symptoms are known as 4 symptom complexes. These are 4 main common symptoms: cough more than 2 weeks, fever more than 2 weeks, unexplained weight loss, and night sweat. There are additional symptoms like hemoptysis, like fatigue, right? These are symptoms, and if patient having extrapulmonary TB, then these patients will have organ-specific symptoms. But weight loss, fever, cough, and night sweat are the 4 symptom complex. These are main symptoms which have been experienced by most of the patients. So if you find out any patient of having TB, you should first identify the TB, right? Second, counsel the patient. It is not normal communicable disease. The treatment lasts for 6 months to more than 6 months, right? So you have to counsel the patient. Still, discrimination and stigma are present for TB disease. So counseling of patient and family member as a family physician is prime importance, because after we use many bactericidal drugs, rifampicin, isoniazid, having good results, right? There are many bactericidal drugs, many new drugs are available under NTEP: bedaquiline, delamanid, pritomanid, linezolid. These are bactericidal drugs. These drugs have ADR. And as we have started daily regimen, the chances of ADR is higher, right? So you have to counsel patient about the disease, how they have gained TB from other patients, what is the importance of nutrition, what is the importance of immunity, right? what is the importance of taking daily regimen, what is the importance of having good treatment adherence, how to identify an ADR. If they have ADR, then whom to contact. These are the main things. And what we generally find that after 1 to 2 months, after relieving of symptom, patient usually stop treatment, right? And in private sector, there are higher chances of stopping treatment because sometimes private doctors cannot follow up those patients, right? So counseling of patient and family members for TB is prime importance. Third one is sample collection and transport. So in the end TB target, we have seen that there should be no catastrophic cost due to TB, right? So we under NTEP usually transport sample, not the patient, right? So if a patient comes to you, you can take sample and you can transport those patients to nearest public health facility. We can also provide you an incentive of 25 rupees per transport to your non-salaried staff. Your staff should not taking salary from government, right? So non-salaried staff, we can provide the non-salaried staff 25 rupees per sample. Fourth one is treatment initiation. So you can start treatment from private sector as well as from NTEP. In NTEP, diagnosis and treatment is free of cost, right? In NTEP, diagnosis and treatment is free of cost. And you can refer those patients to nearest public health facility. Fifth is monitoring treatment adherence. We have already discussed this because 6-month treatment is necessary. First 2 months treatment is for prevention of transmission of disease. But after 2 months, 4 months of treatment is for prevention of relapse. So first 2 months is programmatically more important for prevention of transmission. But last 4 months is more important for patient because if he cannot take treatment for last 4 months, he will have relapse of TB. And most of these relapse are within 2 years. Within 2 years of treatment interruption or treatment completion, right? So treatment adherence is most important. Then follow-up, laboratory follow-up after 56 doses and 112 doses. Clinical follow-up every monthly. I'm reiterating, clinical follow-up is necessary. Clinical follow-up is necessary because we have shifted from alternate day regimen to daily regimen. And post-treatment follow-up, that is after completion of treatment, 6 monthly, 12 monthly, 18 monthly, and 24 month follow-up of TB patient. Because relapse of TB is possible within 2 years of treatment completion or of interruption. Then contact tracing. Contact tracing means tracing of possible TB cases in household contacts, at workplace, and in the vicinity of the patient's household, right? And if patients are giving consent for taking TPT, you can provide TPT. If patient is symptomatic, then you have to identify TB. And if patient has TB, then you have to start AKT, right? AKT is for TB disease. TPT, that is TB preventive treatment, is for TB infection. These both are different things. TPT will be provided to TB infection patients and TB AKT will be provided to confirmed TB patients. In AKT, we are providing multi-drug therapy. In TPT, we are providing either monodrug. We have seen in the table, it is either 6H means daily 6-month isoniazide or 3HP means weekly 3-month isoniazide plus rifampicin. And the third one is 3HR, that is daily 3-monthly isoniazide plus rifampicin. But as a family physician, you have to ensure that patient should take TPT or AKT for right duration, right? So many of the times, if patient has been offered TPT under NTEP, some private doctors usually stop this medication, that this is not needed. right? It is proven, and we have documents, we have research articles that TPT can provide beneficial effect up to 60% in general population and 90% in PL-HIV for preventing breaking up to TB disease from TB infection, right? So TPT and AKT should be monitored for each and every visit of TB patient or TPT regimen. And the last one is availing nutritional or psychosocial support. So on 9 September 2022, our Honorable President has launched Pradhan Mantri TB Mukt Bharat Abhiyan. And from this Pradhan Mantri TB Mukt Bharat Abhiyan, any person can be registered himself as a Nikshay Mitra. Nikshay Mitra means it is registering themselves as a Nikshay Mitra and providing 6-month nutritional support to TB patient. So NTEP program is taking consent from diagnosed TB patients if they want to have a nutritional support from a random donor. And if you want to be a donor or if you want to adopt this patient, right, you can adopt this patient and provide a sustainable nutritional support that is at least 6 months in your district and in your state. You can inquire about this Pradhan Mantri TB Mukt Bharat Abhiyan. There are many nutritional packages are available from 500 to 2,000 rupees per month. We are providing this nutritional support to TB patients, right? So these are the symptoms of TB, and there are many key population. Key population means having higher chances of getting TB. So we have already discussed about the TB symptoms. Coming to the key population, that is contact of microbiologically confirmed TB patients, PL-HIV, diabetes, malnourished patient, cancer patient on immunosuppressive therapy, organ transplant therapy, and healthcare worker. These are the main personnels which have higher chances of TB disease. So this is the standards of TB care in India published by WHO in 2012, which mentions 26 standards of diagnosis, treatment, public health action, and social inclusion for TB patient, irrespective of public or private sector. So a patient in India having TB, getting TB treatment either from public or private sector must be offered 26 standards of TB care. These include these headings, that is counseling, right? So we have already discussed counseling of TB patient and patient's family members, universal drug susceptibility testing. That is, within 15 days of diagnosis, you should have the result of rifampicin resistance, right? Within 15 days of diagnosis, you should have the result of rifampicin resistance to every microbiologically confirmed TB patients. And in rifampicin resistance cases, you should have the result of FQ sensitivity, that is fluoroquinolone sensitivity, within 15 days of diagnosis of rifampicin resistance, right? So there are these categories. First is in microbiologically confirmed cases, having rifampicin resistance results within 15 days, and in rifampicin resistant cases, at least FQ sensitivity within 15 days of diagnosis, that is universal drug susceptibility testing. So NTEP program has streamlined the treatment, and there are all oral treatment, right? So for DHTB and DRT, there are no injection available under NTEP. For certain cases, there are injections available, but in regimen, right? For DHTB or DRTB, these are injection-free oral regimen for better treatment compliance, right? And for programmatic feasibility. So third one is screening for comorbidities. That is screening for diabetes, HIV, and tobacco consumption. Treatment as their adherence for 6 months. follow-up care, that is clinical, laboratory and post-treatment follow-up, contact tracing, TB preventive treatment, and direct benefit transfer, right? So under NTEP, we are providing monetary incentive to direct patient's account, right? So it is known as Nikshay Poshan Yojana, 500 rupees incentive every month for 6 months, right? That is Nikshay Poshan Yojana for availing additional nutritional support, right? So these are various DBT schemes available under NTEP. First one is Nikshay Poshan Yojana. The beneficiary will be TB patient, notified TB patient, right? I am reiterating notified TB patients. Notified means TB is a notifiable disease, right? And every sector, public or private, should notify a diagnosed TB case, right? So notified TB case patient will be offered Nikshay Poshan Yojana every month, 500 rupees. Then treatment supporter honorarium. So I have already discussed treatment supporter will be a person, any person who will be accessible, acceptable, and accountable for completion of TB treatment, as well as ensuring follow-up, all follow-up, clinical and laboratory follow-up, who will ensure a nutritional and psychosocial support, right? And who will counsel TB patient and identify ADR. He will be treatment supporter. So in government sector, there are government staff who are being treatment supporter. In private sector, a private compounder, right, or your receptionist can be your treatment supporter. So for DHTB, on completion of the TB treatment, right, he will be entitled for getting 1,000 rupees of incentive. The treatment supporter will get this money directly. It will be transferred to his bank account. And for DRTB, he will be entitled for 5,000 rupees of treatment support. For private practitioner, that is for MBBS and above, not for BMS, BHMS, right? So for private practitioner, there will be a notification incentive, that is 500 rupees, and outcome incentive, that is providing valid outcome, right? So after providing valid outcome, a private doctor will be entitled for 500 rupees for outcome incentive, right? So what about other faculties, that is BHMS, BAMS, for any layman, right? So there is another incentive which is known as informant incentive. So any person can be informant. If you suspect TB disease in any person, you can be entitled for informant. You can get yourself registered as an informant. And if those patients will have TB and will be diagnosed TB in public sector, right? Confirmed TB in disease will diagnose in public sector, then an informant can be entitled for 500 rupees as an informant incentive under program. So for doctors, it is private practitioner notification incentive. For others, right, BHMS, BMS doctor, for quakes, for health workers, it will be informant incentive. And if a TB patient is taking treatment from a tribal facility, that is his facility is located in the tribal area, then he will be entitled for 750 rupees of the tribal support incentive for transportation in the tribal area. So these are the various gazettes which has been published by our government. It signifies that TB is a notifiable disease, and not notifying a notifiable disease is a punishable offense, right? So the first one is for laboratory and private practitioner and hospital. Second one is for public health action. And the third one is chemist and self-notification by patient, right? So mainly you have to notify TB, right, to various government systems. So the first one is the Nikshay. Nikshay is a software, right? And you can register yourself in Nikshay. You can register your facility in Nikshay. There are several benefits of getting registered in Nikshay. First is you can avail your notification incentive. You can notify patient in the digital media. Yeah, you can very well track those patients. So private sector follow-up of patient and tracking patient is very difficult. In NAKSHA, you can track patient and you can ensure treatment adherence, and you can also supervise public health action. So as a private physician, if you cannot ensure public health action, you can transfer those patients to government sector. Government staff will take public health action, right? You will not lose your patients. So that is the hidden apprehension in private physician and in family physician, that if they transfer those patients, they will lose their patient. No, you will not lose your patient. You will get your notification incentive, and at the time of providing outcome, you will get your outcome incentive. But public health action means counseling, comorbidity testing, contact tracing, providing TPT, direct benefit transfer. These are services available free of cost for public and private sectors, right? So if you cannot provide in this public health action, or you cannot ensure this public health action, we would help you in providing these public health actions. So we are grateful for your everlasting support, and thank you. That's all from my side. And okay, so we are now open for question and answer. Am I audible? પ્રજ્ઞેશભાઈ, તમારું માઇક બંધ છે.
Yeah, there is few questions. One very practical question is that if the patient is taking anti-tubercular drugs from private for 1 and 2 months, and then after due to any reason he want to enter in this government treatment program, then what to do?
So very good question, sir. So there are two scenarios. If a patient is not affording the this AKT from private sector, we can put government AKT to private doctor if doctor is willing, right? And the doctor will very well dispense those AKT to private patient. Now, if patient want to take the treatment after 1 to 2 months from government sector, then doctor can refer those patient to government, and this transfer out facility is available in NAKSHA. If he doesn't want to go into detail in NAKSHA and this software, then they can contact our district TB officer or district TB team. There are senior treatment supervisor and TBHV available under every block level. So they can contact them. Those patients can get treatment from government sector even after completion of treatment, interruption or completion of treatment after 1 to 2 months in private sector. But we can put our AKT in private sector also, right? And they can dispense free of charge. The prerequisite is free of charge because government is providing treatment free of charge, right? So they cannot take money from those government supply of AKT.
Okay. The second question is, when the patient is on AKT from the NTEP program, then if due to any reason patients interrupt the therapy, then and come after 1 or 2 months, then how this NTEP program will recover that patient in the scheme?
Okay, so under NTEP in public sector, we usually link patient to treatment supporter, right? Treatment supporter can be any person who are accessible, acceptable for the patient and accountable to complete the treatment. So in NTEP, there are ASHA workers, MPHW, or pharmacist or family members can be a DOT provider. Earlier, the name was DOT provider, but now we are telling them treatment supporter. right? So these treatment supporters are going to visit their home every day, and in a single day, if patient is not there or if patient has interrupted treatment, he will inform the PHI, right? Public health institution in the locality. The medical officer, the MPSW will visit those patients and would try to recover those patients. But if there is interruption of treatment for more than 2 days, then the district team will be informed and the district team will take action to reinitiate the patient and to recover those patients who are lost to follow-up, right? So in NTEP, the guideline of lost to follow-up is consecutive 1 month of treatment interruption. So if we cannot find those patients, right, for 1 month consecutively, or if patient interrupt drugs for 1 month consecutively, we label them lost to follow-up patient. But this generally doesn't happen in NTEP in public sector, because treatment supporters are visiting patients every day at their home and they ensure dots, right? Dots means directly observe treatment in front of them. So it is not possible under NTEP. It can be possible when the patient is not linked to the treatment supporter, right? Sir, over to you.
One more question, and I think it is the last question. That if the patient is on AKT and if patient is having some side effect like alter LFT or anything, then what is the regimen or what is the policy in this NTEP program?
Okay, so very good question. So earlier it was alternate day regimen, right? But alternate day regimen have higher chances of relapse. So we have started daily regimen, but now daily regimen has higher chances of ADM. And most of the drugs under NTEP that is available under DSTB treatment, that is HRZ, are mainly hepatotoxic. So there are guidelines available under NTEP for medical officer to re-challenge or de-challenge drug. They can omit and sequentially add these drugs. But after this SGPT, SGOT results, these are rare cases, right? So in chronic alcoholic patients or patients having pre-existing liver disease, there are chances of having hepatotoxicity, right? But there are many other side effects, that is GE symptoms, peripheral neuropathy, which are more common than this hepatotoxicity. Programmatically, for every ADR, there are management, and NTEP, under NTEP, we are training our medical officers and our private doctors for management of this ADR.
There is no more questions, so
can I ask one question, please?
Yeah, please, Raman.
Yes, sir.
Dr. Raman.
Yeah. So, is there any punitive action against private practitioners if they do not inform the district tuberculosis program regarding any private patients they are treating?
So as per the Gazette notification, TB is a notifiable disease, and not notifying a notifiable disease as a offense. So we usually don't, as a district TB officer doesn't take any stringent action, but they ideally they should inform those doctors who are not notifying. But after repeatedly not notifying those TB cases, they can take action. There is only one example in Ahmedabad Municipal Corporation. The CTTB officer has taken action, and several punishment have been offered by the state to the doctor.
There is another scenario. I mean, because of many times because of the stigma attached, many tuberculosis patients do not want to go into private or public sector. I mean, they want to get treated privately. They want to maintain their privacy also. Second is that at times they do not have sufficient faith on public health system. I mean, they do not want to go and experience in the government setup the chaos or crowd normally which public sector or government hospitals are identified with. So in such scenarios, couple of times I have they've just advised based on the microbiological report ATT on few patients, but it happens that the labs do often inform the district authorities. So those patients automatically get some call from the district tuberculosis program, and they are normally inquired about their treatment, what treatment they are taking, whether they are following treatment or not. So this is happening a couple of times, and many times patients are apprehensive if their doctors if their doctor has informed the government officials or not, something like that. So there is a communication gap or loop which we should try to bridge. Some kind of trust also among the three parties of public sector, private, as well as the patient community.
Yes, sir. So I would like to very good question, sir. Basically, patient can take treatment for public. We have no control on patient whether he would like to take treatment from public sector or private sector, right? So patient can take treatment from everywhere, but as a private practitioner, you have to I have shown the standards of TB care of India, which was published by WHO and Government of India, and these standards mentions 26 standards to be fulfilled and to be offered to every TB patient, right? So what you have a valid apprehension. What you have told that government sector staff are calling patient that whether he or she having TB disease, are they taking treatment? They are actually asking for bank accounts, right? This is the main apprehension in patient as well as in private sector doctors. But why are they asking bank accounts? Because of this direct benefit transfer, right? We want to transfer NPY benefit to TB patient's account. So as a family physician, first importance is counseling of TB patient, that there are stigma and discrimination in TB patients, and you can manage the stigma and discrimination only by counseling, right? So these benefits, whatever benefits or whatever services I have discussed, these are available under NTEP. And if a private physician cannot ensure these benefits or services or public health action, they can transfer those patients, or without transferring, register themselves in NAKSHI under their PHI, and then you can inform patient that I am informing government facility. If you give consent, and government staff will visit you and will ask for bank account details, will counsel you, they can monitor you if you wish. But if still patient doesn't want to contact government facility, then notification will be provided by private facility, and public health action can also be ensured by private health facility. You need not transfer those patients, or you need not tell DTO about those patients. We will not visit those patients, but you have to notify those patients, right? And we are calling mainly for the NPY benefit, for the direct benefit transfer. But you have to counsel those patients. Sir, basically problem क्या होता है सर, कि पेशेंट को पता नहीं होता, अभी फ्रॉड बहुत होते हैं, इसलिए पेशेंट को ऐसा होता है कि भाई अकाउंट डिटेल्स क्यों मांग रहे हैं, राइट? Because we are running a public health program, we have to monitor all those cases, and we have been reviewed from the highest level because it is a flagship program from the Prime Minister. So these public health actions are being reviewed from the highest level, from the Prime Minister's office, right? And if you cannot provide this public health action, you have to counsel those patients that these public health actions are available for you under an NTEP free of cost. And these are benefits for availing these services, right? So you can counsel those patients, but it is up to the patient. They want these services or not. If they do not, notification is your responsibility, sir. So you have to notify those cases. They can forego those incentives. They can forego the adherence mechanism available, TPT, everything. But you have to notify those patients, and notifying means we will know that these patients have been notified in your facility. The government will know, and we can telephone or we can communicate you or patient. So you have to counsel those patients, then government, they can expect a call from government sector also, right? But we will not disclose identity of the patient to the public.
Thank you very much for the clarification. Very useful.
Yes, any more question, Dr. Raman Kumar?
No, I'm fine. Thank you.
Oh, thank you very much, Dr. Hardik, for a nice, lucid update on the government program to end tuberculosis. Thank you. Thank you very much. Thank you very much all
Thank you,
for
sir.
joining this. Thank you very much.
Thank you, sir. Thank you for the opportunity, sir.